Now that you have the clinical science down behind nasal ventilation and you know the features of the SuperNOVA device, it's time to learn how to actually pitch the SuperNOVA device to customers and clinicians. We start the presentation off by explaining what the SuperNOVA is. The SuperNOVA is the only nasal ventilation platform in the OR that utilizes the clinical benefits of both nasal CPAP and nasal ventilation. Now, this is very important because it allows the clinician to provide continuous ventilation through the nose, even while the other clinician requires access to the mouth for procedures such as upper endoscopy, transesophageal echocardiography, and even endotracheal intubation. Once we've explained what the SuperNOVA device is, we immediately go into the clinical benefits behind the SuperNOVA, as well as the clinical science. Typically, what we like to present is the following. Mass General compared full face mask ventilation to nasal mask ventilation in a head-to-head study. What they showed was that nasal mask ventilation was actually superior compared to full face mask ventilation. They showed nasal mask ventilation had lower peak airway pressures for the same tidal volumes, on average 17 centimeters of water pressure versus 25 centimeters of water pressure, and they had higher flow rates. Now the physiology is as follows. With a nasal mask, you're only pressurizing the nasal chamber, which means pressure goes into the nasal pharynx and stents open the soft palate from the retropharyngeal wall and actually lifts the tongue off of the soft palate, helping to relieve that obstruction. With a full face mask, you pressurize now the nasal chamber and the oral chamber. When you pressurize the oral chamber, it actually drives the tongue back into the soft palate, which drives the soft palate into the retropharyngeal wall, worsening obstruction. Once they understand the clinical science behind nasal ventilation, once we have them intrigued with nasal ventilation, we then identify for them the problem that they're currently having. For example, the pitch would go something like this. Every time you give a patient propofol, you induce two things. Number one, upper airway obstruction, and number two, hypoventilation, which eventually leads to atelectasis. Now we know that it's been proven that both nasal CPAP and nasal ventilation prevent and treat both upper airway obstruction and atelectasis. However, how often do you actually use nasal CPAP in the OR? And the answer is barely ever. And the reason? Because there's no simple and effective method to do so. Now, another question. How often during these cases, maybe it's an endoscopy, transesophageal echocardiography, or even during intubation, after you give propofol, you're sitting there waiting, knowing that the patient is going to desaturate and hoping that the patient will eventually breathe before their saturation drops too low. The SuperNOVA can be used to apply both nasal CPAP and nasal ventilation. Nasal CPAP will help with stenting the airway open during those deep sedation cases where you know upper air obstruction is going to occur. And you can then use nasal ventilation to help actively inflate the lungs to prevent and or treat atelectasis. Now, the good thing about the SuperNOVA is we can even do this during procedures where the clinician requires access to the mouth. Once the clinician understands the SuperNOVA's benefits for deep sedation, it's time to walk them through the SuperNOVA's benefits, the laryngoscopy, and endotracheal intubation. The pitch goes something like this. In today's practice, patients are getting bigger and more sick. And I'm sure that you've recognized that patients seem to desaturate during laryngoscopy that much faster. The SuperNOVA was designed to provide continuous oxygenation and ventilation through the nose during intubation. Now, you can have an unobstructed view of your airway while your patient is still being ventilated. Next,
you want to walk the clinician through the other advantages that nasal mask ventilation has. First, we typically start off with how it has a better seal. The pitch is as follows. With a full face mask, we're taught to pull the jaw and face to the mask, actually lift it to the mask. The reason for this is because if you push down into the jaw falls forward and the head flexes, which would worsen upper airway obstruction. Well, with a nasal mask, as you can see here in the picture, all of the structures around the nose are solid, immobile structures. Now, no matter how hard you push down into the mask, nothing will move and the seal will actually get tighter. Another difference with nasal mask ventilation is you can see here that the fingers are pushing up against the submental space. The objective is actually to gently apply pressure, which will push the tongue back into the oral cavity. This will close it off so that there will be no leakage out of the mouth. And again, will allow for pressure to build up into the retropharynx. Second, you can see it's much smaller. So clinicians that have small hands, it's easy to hold. Also very important, it doesn't cover the nose and the mouth. One of the common complaints that patients will have is that they feel claustrophobic when a full face mask is on. With a nasal mask, they feel less claustrophobic, and since they don't have anything covering their mouth, they can still communicate with you. Next, you want to walk the clinician through the SuperNOVA's design and point out the clinical benefits behind its design. Let's first start with the anesthesia port. The pitch goes as follows. A traditional anesthesia mask, the circuit is in the middle of the mask and points vertically up. Now, if you were to try and intubate a patient while ventilating them with a typical anesthesia mask, the circuit would get in the view of your airway. However, the SuperNOVA's design, as you can see here, the anesthesia port is at the nasal bridge, and it's also parallel with the patient's head. It was designed like this so that you can continue to ventilate the patient through the nose, as well as have an unobstructed view of the airway during laryngoscopy. Also, the reason why it's located up near the head as opposed to in the middle of the face is for procedures such as upper endoscopy or transesophageal echocardiography, where the clinician may need access to the mouth. Now, the anesthesia port is well away from the mouth, and the clinician will continue to be able to perform his procedure. The next feature that we typically go over is the SuperNOVA's supplemental oxygen port, and it has two very important clinical functions. Let's discuss the first. When a clinician goes to perform either direct laryngoscopy, video laryngoscopy, transesophageal echocardiography, or upper endoscopy, essentially anything where the mouth is open, you will have some gas leak out of the mouth and some gas go into the lungs. In order to compensate for the gas that is leaking out of the mouth, we can connect supplemental oxygen tubing to the SuperNOVA's supplemental oxygen port, add an additional 15 liters of oxygen per minute, which will help compensate for that leak out of the mouth. Now, its second function is that it helps save time and allows for a rescue device in PACU. Typically, what we do with the current anesthesia mask at the end of the case is we throw it out. We then apply a supplemental oxygen source, such as an oxygen face mask, and transport the patient to PACU. With the SuperNOVA device, you can actually keep the same SuperNOVA on the patient's nose, connect supplemental oxygen tubing to the supplemental oxygen port, and transport the patient to recovery with the same SuperNOVA. Now, if the patient has a respiratory compromise in the PACU, we'll already have a positive pressure ventilating device on them. Next, we explain why the SuperNOVA's nasal seal is thin, and the pitch goes like this. The typical anesthesia mask has a thick balloon, which you're all familiar with, which is fine for full face mask ventilation. However, if you try and use it for a nasal mask, it can tend to block the nares, which will obstruct oxygen flowing into the nose and therefore into the patient. SuperNOVA's nasal seal is thin and prevents any obstruction of the nares. Therefore, oxygen and pressure can continue to be built up into the nasal pharynx and therefore into the patient. We then explain the clinical benefit behind the SuperNOVA's Velcro strap. And the pitch goes like this. We know that workflow is very important these days. So in order to help improve workflow, the SuperNOVA's Velcro strap already comes pre-attached. That way, once you place the SuperNOVA on the patient's nose, you only have to strap one side in and you'll be ready to ventilate your patient. The final feature of the SuperNOVA's nasal chamber that we go over with the clinicians are the duckbill valves. And the pitch goes like this. The duckbill valves serve two functions. If you see here, these are two one-way valves. When the nasal chamber is by itself, these valves are closed. This prevents any leakage of gas coming through them and helps maintain the SuperNOVA's seal. The second function is that they serve as attachment sites for different products.
Shown here is the SuperNOVA's first accessory, known as the oral chamber. The oral chamber has two proboscises, which are essentially openings. When the oral chamber is inserted into the nasal chamber, these proboscises allow the duckbill valves to open up, and this allows for bilateral flow through the nose and the mouth, essentially acting as a full face mask. The other feature here is similar to the nasal chamber's feature. It also has a Velcro strap. This will allow for hands-free full face mask ventilation.